Welcome, everyone. The first session on the last day of EHBEA. It's my pleasure to introduce today's speakers, and we're going to start off with a plenary talk from Grazyna Jasienska, who is going to talk about evolutionary perspectives on women's health. And most of you are aware she's been writing about this topic quite eloquently in a book called The Fragile Wisdom and in a whole series of different articles over the past couple of decades at least.
First of all, I would like to thank the organizers for inviting me to this very interesting conference and superbly organized conference. So thank you very much. I'm very happy to be here. So I'm going to talk about women. I'm going to talk reproduction and health and connection between reproduction and health using sort of evolutionary perspective, so going a little bit to evolutionary medicine. So if you went to the debate last night, you will maybe find some the same general idea that people were talking about yesterday. So we know that fertility in women is affected by many different factors. There are cultural, social, economical factors. But in fact, for those factors to have impact on fertility of women, they need to work through physiology. They need to work through ovarian function. So I'm going to talk about ovarian function, of reproductive physiology of women, but just concentrating on ovarian function. We study this because, for me, one interest is trying to understand the evolution of human life history, but I'm also working in public health. So for me, implications for health are really important. When it comes to ovarian function, we have a lot of understanding right now, still not enough, but we know that what women do at different stages of their life is important for ovarian function, and this is important for fertility and health. We know a lot about factors that are operating during adult life, but we are also starting to learn that childhood conditions are important for ovarian function and for fertility. We know that fetal conditions are important, so conditions in which a woman is developing as a fetus. And one thing that connects all those factors that are influencing ovarian function is in fact energy. How much energy a woman has at a given time. And we see that ovarian function, this reproductive physiology, is very sensitive to energy. So most of the factors that we know that influence ovarian physiology are something that causes what we call suppression of ovarian function. This suppression occurs when a person has not enough energy. And when somebody is in a very good nutritional status, then ovarian function is operating at the high levels. Of course, there are also, as everything else, ovarian function is also affected by genetic factors. For some people here, also maybe not only connection to life history, not only connection to health is important, but also to mate choice, because when people study mate choice, they are often interested in what's going on in cycles, menstrual cycles of women. So ovarian function, I'm going to talk about very specific group of women. I'm going to put aside completely any kind of women who have any problems. So we are not going to talk about any pathologies. We are going only to look at women who are healthy, who are in a similar age range, and who have regular menstrual cycles. And in such defined group of women, I'm going to ask, do women differ when it comes to ovarian function, and what causes this variation? Why do they differ? you don't need to know much physiology to being able to follow my talk. The only thing that would be useful is just like the third panel from the top, you see levels of two hormones, estrogens, and in fact what you have in menstrual cycle is called estradiol, and progesterone, two hormones. Without sufficient levels of those hormones, there is no ovulation, there is no implantation of fertilized eggs, so there is no pregnancy. And I'm going to show you a lot of data when these hormones will be present. So, but that's the only physiology that you need to know. So, if we look at progesterone levels, and we're looking at 5 different populations. We are comparing average progesterone levels, and you could see that there is a lot of variation. Those populations are populations in which hormones were sampled and measured at exactly the same way, so we can compare them. And you could see that women from, this is Democratic Republic of Congo, have very low levels of hormones. Women from Poland and US much higher levels of hormones. So you could see that there are some differences when you just look at average women in a population. When we look at the women in a single population, and in fact here the word population is a little too much, because this is one small village in Poland. And what you are looking here, you are looking at 4 hormonal progesterone profiles for 4 different women. Profiles, you get profiles when you sample hormones every day, and that's what we did in our study. Women are collecting saliva samples, and in these saliva samples we are measuring hormones. So we get those beautiful profiles. But here, it's easy to see that there is a lot of variation. This woman who has this red profile has very low levels of hormones. Woman with yellow is sort of intermediate, and woman with blue has very high levels. All those women have regular menstrual cycles, but very different levels of progesterone. These are 4 different profiles, consecutive profiles from a single woman. And here you also could see a lot of variation. This woman produces relatively low levels in July and August, higher levels in September, and very high levels in October. So we have a lot of variation in levels of ovarian hormones among populations. And of course, this variation is due to the fact that individuals are producing different levels of hormones, but we also have a lot of variation among individuals in a single population, and a lot of variation among cycles of the same individuals. So it's not that somebody will produce the same levels of hormones for a couple of years. No, usually each cycle will be different. So the question is, what determines this variation? Why do we have it? I'm going to talk mostly about results of studies that were conducted several years ago, studies on lifestyle and reproductive hormones that we did with many people from different places. And we had almost 200 Polish women and 200 Norwegian women, and this age range in which women have highest levels of hormones. And we did a lot of different things. We collected daily saliva samples in which we measure estradiol and progesterone. We had birth records of those women, so we knew how much they weighed and how long they were when they were born. We did a lot of measurements of body composition, anthropometry. Women collected information about physical activity, making for the whole menstrual cycle daily records of what they did. And we collected information about diet, and we took a blood sample for genetic studies and some other things, but I'm not going to talk about them because they are not relevant right now. We work in Poland. We work in rural area of Poland. When we established Mogielica Human Ecology Study Site, and we are doing lots of different studies. Also, the hormonal study was done there. I work in a university in Krakow, and our study site is just 70 kilometers from Krakow. So it's really very convenient to go and do the field work, but it's a very different world than urban areas. So we have several villages in the areas. Villages are usually located in the valleys between the mountains. This is how it looks. So you could see that this is very agricultural. People are owning fields, usually very small fields, usually very scattered, and this is very traditional, still very traditional agriculture. And it's traditional because use of any machinery, it's very difficult when fields are small and when they are located on the slopes of the mountains. This is all very beautiful, especially during the summer. What's interesting about this region is also that the largest village in which we have in our study site is a village with a very high fertility. Right now, Poland is a country with one of the lowest fertility in Europe, and in this village, women have about 5 children on the average. You could see that some families have 9 and 10, and there is a family who has 16 children. So if you are interested, as me, in fertility, this is a perfect place to be. So we have a lot of children. We are doing some studies of children, but today I'm going to talk about mothers and not children. Because I want to show you how adult environment affects ovarian function. And one of the very important factors is physical activity. And again, this is a good place to study physical activity because women are working very hard, especially during the summer when there is a harvest season, and because there are not many machines, lots of work is done by hand. And women are involved from early morning to late night hours during the harvest. So they have very high levels of physical activity. And if you compare women who work very hard physically with women who don't work that hard, but are still working. When we were beginning the study, I was thinking that we'll be able to compare women who are not working, not physically active, with women who are very active. No, everybody is working during the summer, but some women have higher levels of energy expenditure and other women lower levels. So we are looking at 2 consecutive summers, and the red profile, this is progesterone, comes from women who have lower levels of physical activity, and white profile for women who have high levels of physical activity. So you could see that physical activity suppresses progesterone level. The same is true about estradiol. Physical activity suppresses estradiol. So here we have 3 profiles of women with different levels of physical activity, and you could see that red profile, which is from women who have high levels of activity, is much lower than profile for women who have moderate or low physical activity. What other things about adult conditions are important? One thing that we became interested is not only how much energy you have and how much energy you are moving. So if you are physically active, that you need to mobilize more energy. But we also became interested whether the distribution of energy on the body is important factor. And the idea came, in fact, from the studies in evolutionary psychology, when people look at the different body shape and discover that the particular waist to hip ratio is more preferable that others' body shapes. And so I became interested whether the waist hip ratio, which is narrow waist and wider hips, is something that is related to hormone levels. So we look at the waist to hip ratio, we look at the breast size in women, because this is also one of the traits that men pay attention to. And we ask the question whether there is any relationship with hormone levels. And turns out that there is. Here you are looking at two groups of women. The yellow profile are women with relatively narrow waist in relation to hips, and red profile, women who have broader waists. So, and you could see that the narrow waist women have higher levels of estradiol. They also have higher levels of progesterone. So both hormones are higher in women who have this hourglass body shape. Women who have relatively larger breasts also have higher levels of estradiol. This is especially true in mid-cycle and in the second half of the menstrual phase. If we put those two traits together, it turns out that women who have relatively narrow waists and relatively large breasts at the same time have about 30% higher levels of estradiol than women who have any other combination of these two traits. 30% higher levels, according to some studies on conception, is being 3 times as likely to get pregnant in a cycle. So that's a lot. All right, there are some other factors about adult environment, but I think you got the point. So let's move to fetal environment. And Jonathan Wells gave a wonderful talk 2 days ago when he talked about importance of fetal environment. You know that there are lots of studies, both in humans and other species, that find out that nutrition of the mother and consequently nutrition of the fetus is a very important predictor of physiology and health in later life. And we know that nutrition is related to permanent changes in physiology. So the way the organs are designed, the way the physiology is built, to some extent is determined in utero. And this has long-term physiological consequences. I became interested whether we could also talk about fetal nutritional programming of reproductive physiology, whether reproductive physiology is also to some extent programmed in utero. And of course the question is, how do we know in what condition fetus is developing? In humans, it's hard to do the actual experimental studies, impossible, so we don't know for sure. We have size at birth as an indicator. It's not a perfect indicator, but tells us something. So one of those factors, you could look at the birth weight or birth length, but also you could look at the ponderal index. And ponderal index is sort of the level of fatness of the baby. So it's a little bit like BMI in adults. So we ask the question whether women who differed in their size at birth differed also many years later, about 30 years later on the average, in levels of reproductive hormones. And turns out that they do. So women who were born as relatively skinny babies, when you look at the yellow bar, have lower levels of estradiol than women who were born as relatively fat babies, if you look at the dark orange bar. So there is some indication that this fetal environment is important for future reproduction. But women are not only born with a particular size, but they are also, as we know, doing different things when they are adults. So we could in fact, ask the question whether, if we know the size at birth and if we know the physical activity level in adulthood, what would be the interactive effect of those two factors on estradiol levels? So what are putting two different information about environment at two different life stages will tell us about ovarian function. And when you do that, it turns out it's quite interesting because, in fact, I told you that physical activity decreases levels of ovarian hormones, but here we are looking at two groups of women. They are both doing relatively little when it comes to physical activity, so they are not physically active. And for women who are not physically active, size at birth doesn't matter. For women who are very physically active, size at birth also doesn't matter. And turns out that size at birth is only important for women who have moderate levels of physical activity. And so if we put that together, well, I didn't lie. High activity decreases levels of hormones. The red bars are levels of hormones in women who have high physical activity, and one of them were born with small size at birth, another were born with large size. And physical activity for them just is related to low levels of hormones. If women have low levels of physical activity, again, regardless of size at birth, that have high levels of hormones. This is green bars. And for women with moderate levels of activity, it turns out that size at birth is important. In other words, in women who have moderate levels of physical activity, and if they were born with us big, fat babies, moderate levels of physical activity are not enough to reduce levels of hormones. And please keep that in mind, because this will be important when we will be talking about health. Childhood environment. So women are born with particular size, growing up in particular condition when they are fetuses, doing particular things when they are adults, but how about what nutritional status they have during childhood? Is this important for ovarian function? How do we measure that? Wonderful if we would have some longitudinal studies, longitudinal data. We don't have it for our Polish population. So we used a marker. And anthropologists use leg length as a marker of childhood energetic condition. So in adult women, we are measuring leg lengths, and especially also the absolute length, but especially relative length in relation to body height is a marker of a childhood condition. So somebody who grew up in a good condition as a child would have relatively longer legs than somebody else who's exactly of the same height but grew up in poorer condition, on the average at least. So the question is, do leg length, which is our marker of childhood condition, has any impact on ovarian function, whether there is any relationship between leg length and ovarian function? But we know that other things are important. So we are controlling here for size at birth as a marker of fetal condition. We are controlling for physical activity as a marker of adult condition. And we are asking whether this childhood condition has any effect on ovarian function. So we are putting information about all those three stages of life together. And turns out that yes, if we look at the mid-cycle, if you look at the second half of the cycle, turns out that women who have relatively longer legs have higher levels of estradiol. So this would indicate that those childhood conditions, even when we control for the effect of fetal, when we control for the effect of adult, still are important determinant of what's going on in ovarian function, what's going on with ovarian reproductive physiology in women. I'm just going to mention that genes are also important And when you are interested in genes, there are many possible candidates that you could study. But one which is quite obvious, it's look at the genes that are responsible for encoding enzymes that are involved in steroid production. So here I'm going to show you just one result of the enzyme that is called CYP17. Is involved in two different stages and producing of estradiol and also other steroid hormones. And it encodes one of the cytochromes, and this cytochromes moderates activity of two different enzymes. So enzymes that are involved in synthesis, and we are asking, is it important? So do genotypes of this particular gene differ in levels of estradiol? And yes, they do. So there is some also genetic impact on estradiol level. So women that have one of the homozygotes genotypes have about 50% higher levels of estradiol than women who are also homozygotes but of another type, and heterozygotes are sort of in the middle. So I'm not going to go about other genes, but just so we know that genes are also important. Now, we already know what influences levels of hormones. So let's ask the question, what kind of implication this knowledge has for health of women? So I'm going to move a little bit to this sort of connection between female reproductive physiology and health. And we know very well that estrogen and progesterone are very important hormones for women. And in fact, it's good to have high levels of hormones because high levels are beneficial for many things. Obviously for fertility. High levels increase chances of conception, increase chances of successful pregnancy. They are also important for cardiovascular health. They are important for prevention of osteoporosis. They are important for physiological well-being. So in women, it's good to have, when we're women, it's good to have high levels of hormones. Well, not necessarily. This beautiful woman is, I should show you something from one of the British museums, but I wasn't sure if anything like this exists anywhere in the world, because this is, she was a mistress of the Raphael himself. As you could see, the Raphael died as a relatively young man. He was less than 40 years old. And we don't know much about her. She's called La Fornalina, which means a baker or a daughter of the baker. There's some information that after Raphael died, she entered the convent. Why would a mistress of somebody enter the convent? And probably not because she wanted to become a nun, but because nuns at that time were people who knew most about how to take care of women who had breast cancer. Because nuns themselves often had breast cancer. So if a woman had a breast cancer, she would seek care of nuns. And several years ago in The Lancet, there was a paper written by MD who said that this picture is a representation of a woman. This is the first that we have in art history of a woman who has breast cancer. And he argued that the shape of the breast, the coloring, the dark underarm, the way she points to her breast, the sort of the dentition that you could see there, this means that she had breast cancer. We don't know that. We will never know. But we know for sure that high levels of estradiol, estrogens in general, and also to some extent progesterone, are risk factors for breast, endometrial, and ovarian cancer in women. So on one hand, they are good for many aspects of health, or another, the increased risk of breast cancer, endometrial, and ovarian. this gives us some clue to preventing breast cancer, because if we know that high levels are factors increasing risk of breast cancer, we could ask whether reduction in breast cancer could be achieved through reduction in levels of hormones. So reduction in a woman's exposure to levels of both the hormones that she produces and both the hormones that are supplied from the outside as either contraceptives or hormonal replacement therapy. So could we somehow reduce this lifetime exposure to hormones? First, we need to know why women have this high lifetime level exposure to reproductive hormones. There are like two main reasons for that. One is that women have many menstrual cycles. It is estimated that a woman in a Western country has about 450 cycles per life, and a woman in a more traditional society about 100 cycles, because in traditional societies women are either pregnant or breastfeeding. In addition, women right now mature early, so they are adding few years when they are having cycles to this lifetime cycle number. They are having later menopause probably that they used to have. They don't have children or have very few children, and they are no breastfeeding or breastfeeding for a short time. And even if they are breastfeeding for a long time but have one child, in a lifetime, for the lifetime, exposure to hormones doesn't matter much. The problem with those factors, those are what we call risk, or they are also risk factors for breast cancer. The problem is that they are not easily modifiable. You cannot do much about menarche that's early. You could maybe do something pharmacologically, but no one would do it. You cannot force women to have more children that they want to have. So we know those factors are important. If we could change them, women will have lower risk of breast cancer, but we cannot. But women also have high lifetime levels of estradiol and progesterone because they are having cycles, not only many cycles, but in those cycles, levels of hormones are high. And we know why they are high, because women are not physically active, because women have relatively high body weight, because most women were born with relatively large size and grew up in good childhood condition. These are all factors that are contributing to high levels of cycles and high lifetime exposure to those hormones. We know that physical activity lowers levels of hormones. And in fact, epidemiological studies that are not concerned with measuring levels of hormones, but they just look at the physical activity at particular time or during lifetime and risk of breast cancer, they are showing that physical activity is a powerful factor that reduces risk of breast cancer. We know what the mechanism is. This goes through the levels of estradiol and progesterone. But we also know that its physical activity is not going to have the same effect on every woman. So it's very hard, like, for cardiovascular diseases, we have some recommendation how much physical activity we should do in a day or in a week, and we know what kind of reduction in risk we could expect. With breast cancer, it's a different story, because you could see here that physical activity, if it's very high levels, looking at the red bars, it's going to reduce levels of hormones. But if it's only a moderate levels of physical activity, this is what most women are able to achieve. Very few women are able to be very, very physically active. So moderate levels is something that we are usually recommending. And you could see that if a woman was born as a relatively large child, with this large size at birth, moderate physical activity is not enough to reduce levels of hormones. So we really need to have personalized approach to health prevention in women. We cannot say, do 30 minutes of moderate physical activity every day and you will reduce your risk of breast cancer. Maybe not. Maybe if you were born as a large child, we need to know that, then you will need to do more to see any kind of effect. All this variation in levels of hormones raises a question. If any of you is sort of familiar with more medical research, for medical people, the question usually which they want to know is what's normal? If we see variation, we need to see that one particular levels of hormones, the range of hormones is normal. Something outside this range would be abnormal or pathological. But here, how would we decide what's normal and what's abnormal? We are looking at 4 different profiles. The profile which is in red, that's obviously non-ovulatory cycle, but it's regular. And we know that probably those low levels are a response. There are response to maybe high levels of physical activity. So for reproductive ecologists, we interpret those low levels in such situation as adaptive. We are thinking that this is an evolved response of our reproductive physiology. The fact that this physiology is so sensitive to energetic factors is very important, because reduction in levels of hormones, suppression of ovarian function, something that prevents a woman to get pregnant, is important during times when she does not have enough energy. So whenever she's losing weight or working very, very physically hard, these are not the best times to get pregnant. So it's better to suppress reproductive physiology and wait until the times are getting a little better. So nothing is abnormal here. Everything is very normal, having high levels, low levels. This is normal. Also, how would we decide, looking at the population, which one is normal, which is not? Is US normal? If you look at the textbooks, you will probably mostly see the levels for Western women. So you would assume that US is normal. We would think, when we use evolutionary thinking, we would say that normal is rather closer to Congo, Bolivia. Lower levels. And US, those are levels that are artificially high, artificially comparing to our evolutionary great-great-grandmothers, because our lifestyle changed. So nothing is normal, nothing is abnormal here. So maybe instead of asking what's normal, we could ask what's optimal for a woman. What levels of hormone would be optimal? Here we have another problem, because levels of hormones that are optimal for fertility are not necessarily optimal for other aspects of health. Here for breast cancer. So for fertility, you need high levels. For prevention of breast cancer, low levels. There is no optimum here. Same with different risk of different diseases. So something that's optimal for prevention of osteoporosis, it's nice to have high levels of estradiol if you want to have strong bones. But those strong bones, high levels of estradiol is related to a higher risk of endometrial cancer or breast cancer. So there are no optimal. Low levels are good for one thing, high levels are good for another things. So when it comes to female health, we have a lot of different trade-offs. So we have those trade-offs between fertility and risk of different cancers, reproductive cancers. We have trade-offs between risk of different diseases, and prevention of one disease may mean that there is an increase in risk of another disease. So this is very challenging for health prevention in women. health prevention in women in all aspects that are related to reproductive hormones is very difficult, because you cannot really find the gold standard. It's very hard to do it sensibly. If you are interested in these topics, as Mary mentioned, I published a book in which I discussed this things about hormones that I was talking today, but also many other aspects of female health and many other aspects of reproductive physiology and other aspects of reproduction. I think my time is... You want 10 more minutes of talk, or you want to go to the discussion? Because I'm prepared for either. I could go a little bit to mate choice, or we could... I know for the audience it's hard to say, just finish, yes? Okay, mate choice. A little bit. So I said that having information about physiology, reproductive physiology of women is important for people who are doing mate choice studies. If you are doing mate choice study, you sort of assume that many behaviors that women have depends on their potential fertility, so something that we call fecundity, so levels of hormones. We also think that behavior on men may depend on women's fertility, that men respond to this reproductive state, the levels of hormones of women. That's fine. I think that in order to study this issue, and many people agree, we need to somehow assess fecundity, so this potential fertility, so potential fertility levels of hormones. One thing that is important here, that many studies that are, many mate choice studies are using young women as subject. This is convenient. We have undergrad students, we give them course credit, and they are happy to take part in our study. Fine, but young women have low levels of hormones. There are still, the reproductive physiology is still maturing. Here you're just looking at progesterone. You see the upper graph is for women who are 18 to 19. They have much lower levels and different profile than women who are slightly older. And then, of course, then women after 40 also have reduced profile. So the young women, in fact, are not the most perfect participants. So they have low fecundity, low levels of hormones, and low frequency of ovulation. So they have many cycles that are anovulatory. We don't know because we don't measure levels of hormones, just due to age. Also, there are groups that very frequently are going on a diet, losing weight, gaining weight. They are often physically active, so they have a lot of changes in levels of hormones. Of course, we could ask whether we should care at all about factors that influence levels of hormones when we are doing mate choice study. We may just say that perhaps it's enough to measure levels of hormones. We don't have to know why they are low or high, but just measure the level, and that's enough. But the problem is that, as you know, the levels are hardly ever measured in this kind of studies. People try to predict fecundity from the day of the menstrual cycle. Is it possible? No, it's not. You have 3 hypothetical cycles of 3 different lengths. The one in the middle is your textbook example, 28 days, probably ovulation in the middle, day 14. But the first cycle, the one in the white, is shorter. The one in green is longer. The problem here is that when we are doing the study, we need to do the tests and other things before the cycle is ending, yes? So we don't know whether cycle is going to have 20 days or 30 days because it's still in progress. So when we are trying to sample women in follicular phase, or in luteal phase or around ovulation, we don't really know how to do it, because if cycle had 28 days, that would be simple, relatively, but we don't know. So here, in fact, which is, if there is ovulation, the ovulation probably does not happen on a day, something that we would see as a minus 14. There is some difference. Here there is also some difference. I'm sorry. We would know that if we were able to align cycles on the last day of the cycle, but we cannot. So you could see that what's indicated by then minus 14, and from the day 1 to minus 14, you have something that is probably follicular phase. And in cycles, they're different in length. Follicular phase, of course, is going to have very different length. But we don't know that because cycle is not ended. Another thing is that something that we call fertile window, and of course in mate choice studies people are really interested in when is this part of the cycle in which woman is able to conceive. This depends on the length of the cycle, and also you could see that this is very variable. This is from the study in which people looked when women are in fact conceiving during the cycle. And you could see that there are quite a high percentage of women who could conceive on a day 7 of the cycle. There is some percentage of women who are conceiving on a day 21st. So, of course, around the day 14, there is the higher probability of conception. But it also occurs at completely different days of the cycle. So we have this incredible variation also between cycles, among cycles of a single woman. And we are doing our study usually during one particular cycle. So I'm not sure if this is important or not important, but there is a lot of this inter-individual variation. And the vertical lines are cycle means for progesterone for a single woman. So you could see there are women who are quite close in their cycles values, and there are women who are quite far from one value to another. How many cycles we should sample per woman? Hard to say. Probably if we are interested in some assessment of overall levels of hormones over some longer period of times, this is probably should be more than 1 or 2 cycles. I don't know if inter-individual variation is something, so among cycles is something important to consider. This is not the question for reproductive ecologists. This is a question for people who are doing the mate choice, to think about it, whether we want to only know what's going on during a particular cycle, or we want to know some more overall assessment of fecundity of the person. If you are sampling, we are sampling hormones. If you are familiar with many medical literature, you could see people are usually taking single sample from a cycle, and based on this single sample, they say, okay, this woman has high levels of hormones, this woman has low levels of hormones, this needs treatment, this doesn't need treatment. This is not reliable. And in fact, when you are having just 1 or 2 days, you are making a lot of mistake. This you don't know much. So maybe not all days need to be sampled. This is expensive, but 6, 7, 8, and you already know something about cycle. So it is clear that there's. I'm not following closely the mate choice literature, but I know there is a hot debate right now about this menstrual shift, with lots of meta-analysis done and so on. But meta-analysis is not going to resolve anything if single studies where done with some methodological problems. So I think this is hormone measuring is now much cheaper than it used to be, and if we really want to reevaluate the hypothesis in mate choice by measuring hormones, that would be very interesting to see if we are going to get similar results that we did without measuring hormones. So thank you very much for your attention. Thank you.
We have several minutes for questions, and we've got some.
Hi. I'm Ruben Mausland from the University of Göttingen. I happen to present some results based on counting days. So.
I'm not saying it's wrong.
No, and I don't think you. And I agree with your criticisms. I do think more people in the field have moved to counting backwards, which is a slight improvement. And I think it's maybe a bit exaggerated to say it's impossible, since women are using it for contraception. Can't be all that bad. But of course, you will have more error. And well, I mean, what we did is to try to get a larger sample, and I think that can be part of the solution. I do think it's really hard to actually estimate fertility or conception risk. Continuous conception risk is what people are supposed to be using at the moment, and most do, I think, from women with different cycle lengths. So the literature there is really insufficient for us to actually form an algorithm to estimate that. So this is something, if there was improvement there, I think a lot of the literature could also improve. It's a question of also releasing the raw data underlying, for example, studies like Wilcox, and just release these aggregate graphs, which are really completely useless if you want to do this backward counting method. I think there is a benefit to doing these diary studies like we did, because we can keep women unaware of the fact that it's about hormones, and awareness matters a whole lot. So we see this for a lot of the outcomes that we look at. Awareness really is a moderator, so women who use fertility awareness methods show bigger effects, and I think you're going to find that if you do hormonal studies, because women will know what it's about. So all in all, I think there should maybe be some room for these studies, although I totally agree with you that the methods need to improve. And this was more of a comment, but the question is also coming. I wanted to know whether you could also say something about the pill, because obviously that ties into a lot of the things that you were saying about estrogen levels.
Yeah, the pill normalizes your levels of hormones. So everybody basically taking the same kind of pill, you're going to have the same levels of hormones. So in terms of mate choice studies, I'm not sure whether this is. You could compare women on a pill and women are not on the pill, but whether this is important, I'm not sure. I think that the ideally is to just do study on women who are not taking any artificial hormones, because we don't know what.
With your consideration for lifetime breast cancer risk.
Lifetime breast cancer risk. This is interesting. Because pills are, the results of the studies are mixed, and they are mixed for a reason. Because pill, for some women, pill is not increasing. Some people assume that you are taking pill, you are taking hormones. So for sure, you are increasing levels of hormones. Not true. Because for some women, it depends. What is the natural, what would be the natural way of producing hormones? Some women have high levels of hormones that they produce, and in fact, pill for them is the reduction in lifetime exposure. For some women who are naturally low levels producers, pill could increase the risk. So increase the levels of hormones and increase the risk. So I don't think there is a single answer to that. And individualized medicine, this is something that we need. And we cannot treat everybody the same. And in fact, doctors, when they're prescribing contraception, they should do the hormonal studies. They should see the cycle preferably not one, and then decide what kind of contraceptive woman needs, and then would be sort of learn more about breast cancer risk.
They don't even take the body weight into account. It's completely random.
No, they don't. Maybe.
There's a question over here.
Thank you for your talk. I'm not sure if this is on, but I'll project. I just had a question. You gave a nice overview of all these relative factors that could be contributing to ovarian function, and I was just wondering if you could say something about the relative contribution of those factors to overall. So is it really childhood or adulthood or fetal environment?
Wonderful question. I would like to know the answer to that. If anybody knows, please let me know. We don't have enough studies to know that. There are very few studies like ours that would look at different factors for the same women. You know, you have lots of studies on physical activity, you have studies on weight loss, you have studies on that. There are no studies that would look at and also you would need much larger sample to really look at all the factors comprehensively. So we don't know.
So there's a question.
Yes, here. Thank you. This was Thomas Jamin-Barrett. I learned so much. Thank you so much.
Thank you.
Do you have behavioral data associated with your data? In particular, sexual behavior, mate status, relationship status, relationship satisfaction?
We don't have sexual behavior, although we did a little bit of the mate choice study on our women. We have a also we ask them about mood and things like that, but you know, not really thinking how this will influence levels of hormones, but whether hormones are important for all of those things. And so we look, for example, and women reported how they feel during different days, and we look whether those feelings are in a way influenced by levels of hormones that they have. But it's sort of, this is still in progress.
This might be a mechanism for. So this might be a mechanism for behavior. Yeah? So if you are in a particular relationship situation, for instance, this might be what's driving your behavior, which would be very interesting to link up.
You mean the hormones might be driving your behavior, or?
So you say you are in a particular relationship situation in which you have some kind of strategy, and this might be the proximate mechanism with which that strategy.
Yes. Yeah.
Have you looked at that?
No.
I want to talk to you.
Right. Here.
Hello, Yannick from Bern, Yannick Lutmeyer. Thanks from my side. I really enjoyed this talk. My question is about the what you said about the physical activity that reduces estradiol. Do you know or do you have a clue what the underlying mechanisms are? I mean, are these women producing less estradiol from the beginning, or are they metabolizing the estradiol to testosterone? Because you didn't say anything about testosterone, and it could be interesting to see whether these women that are highly physical active have have higher testosterone levels.
Yeah, we haven't measured testosterone. We didn't have enough saliva for doing all the studies. That's a good question, and I don't know. What's the actual? We know that because we are measuring levels in saliva, we know that this is not. We are not talking about metabolites or anything. We are talking about the sort of the first step of hormonal production. So we are talking what's really circulating in the body, but what's the actual steps in synthesis? We don't know.
We'll take one more question.
Hi, I'm Husna from UCL. I would like to ask, as you said that the fetal programming body weight may affect the ovarian function and fertility, how about the preterm baby? Does the body site including those preterm baby from the data of the study?
Preterm baby.
Yeah, and because preterm baby has different catch-up growth and perhaps the menarche age as well. So I would like to have your comment about that. Thank you very much.
You know, we only look at the size of those. We didn't have any women who reported or to have information that they were really perturbed. You know, there are some studies in pain than on preterm women, and they have lower levels of hormones.
All right. Thanks very much.